Are we going to use the hand mic, or are we going to turn this up? Okay. So we are going to move to a second and final panel. In this case, we're going to try, so in the initial panel, that was really I wish everybody had like a half an hour to talk instead of 3 minutes to talk, but that was an incredibly enlightened discussion from a variety of perspectives about integrated care and its potential ramifications clinically, economically, practically, from a kind of a systems policy level. We're going to cone down, so this was like a Google Earth satellite or image. We're going to cone down from the 20,000-foot level to closer to the ground and hear the perspectives of some individuals that have expertise and enlightened views about this from different relevant areas within the healthcare system. And to do that, I'm really happy to welcome our panelists, including Dr. Henry Chung, who's the medical director of the Montefiore Accountable Care Organization, associate professor of clinical psychiatry at the Albert Einstein College of Medicine, Dr. Frank deGruy, who is the Woodward Chisholm professor and chair of the Department of Family Medicine at the University of Colorado, Dr. Keris Myrick, the president of the National Alliance of the Mentally Ill, of Mental Illness, National Alliance of
Mental Illness.
National Alliance
on mental.
On mental. Just like my text says. And I want to also thank particularly Dr. David Bromberg for stepping in on relatively short notice to participate. Dr. Bromberg is a general pediatrician practicing in Frederick, Maryland, in these credential and behavioral and developmental pediatrics, and serves as the district chair of the American Academy of Pediatrics Mid-Atlantic region and is on the board of directors there. So thank you for all for being here. We're going to begin with the same format. Ask each panelist to make some introductory comments, limiting it in time to a couple minutes, and then we're going to take questions from the floor. So Henry, would you start us off?
Great. Thank you, Dr. Lieberman, and thank you, the American Psychiatric Association, for inviting me and giving me an opportunity to talk about an area that is so passionate to me. I'm currently at Montefiore Medical Center. Montefiore Medical Center is an academic medical center in the Bronx County of New York City. And I guess you could describe the Bronx County as a large safety net population. 50% of the county has Medicaid, and Montefiore has been serving that population for a very long time with a passion for bringing in treatment for behavioral health disorders. But with the advent of the Accountable Care Organization, of which Montefiore is a part of that movement, and taking responsibility for the care of that population, and by accountability, I mean both cost and quality, that we have to be attendant to that and to look for opportunities to coordinate care, because we're convinced that if we do that well, we're going to do right by our patients, the people we serve, and also do right via the stewardship we have over the healthcare costs. Behavioral health integration is a key part of the accountable care strategy at Montefiore Medical Center. And I would describe that in the following way, that there are multiple pieces of integration that need to be attended to when you're talking about a large population. First is you want to employ the collaborative care model, the impact model, if you will, in every outpatient general medical setting, and we are striving to do that. We also want to embed primary care and wellness services in traditional behavioral health settings because of the data that suggests poor access to medical care. We now also want to embed this type of integration in our care management models. Our care management models, or case management models, if you will, are for those with the most complex illness, the highest cost, the greatest difficulty being loyal or being managed in a continuous care process. We've been fortunate because we have strong leadership and we have great momentum in all of these different sectors. Here's an example of how this might work. In one of our major primary care sites, we have a patient, this is a prototype patient, who has diabetes, high blood pressure, chronic pain disorder, who has been using the emergency room quite frequently because of difficulty managing her blood sugar. And her primary care physician has been frustrated because after multiple attempts to refer the patient to traditional behavioral health, she's been unable to really stick with that process. And meanwhile, she is clearly cycling down a road of chronic kidney disease, high cost, significant suffering. What we were able to do in this situation is to apply the collaborative care model where a social worker meets with the patient right then and there, referred in a warm handoff, to assess the situation and to look at what can be done. We apply the PHQ-9. We're using other metrics like an anxiety scale. And not only did she have depression and anxiety, which was untreated for a long period of time, but she also has trauma issues, which has not been uncovered until the time of this assessment. We were able to have a psychiatrist not see the patient, but coordinate that treatment plan with the social worker and provide some psychopharmacology recommendations that the primary care doctor can quickly act on because they have the knowledge that a psychiatrist has reviewed this. And although many general physicians use antidepressants, they are wary about optimizing the dosage or thinking about side effects. This social worker provides then the safety net through ongoing measurement using the PHQ-9 and the GAD-7, and even an alcohol measure, to find out how she is doing over time. And here's the interesting thing, is that even though I talked about psychopharmacology, our data suggests that in this type of prototype patient, that 60 to 70% of them opt for some form of counseling, that they would prefer to do that rather than go with the medication option. And so this patient was given the option of both face-to-face therapy as well as phone-based therapy. And in fact, she opted for phone-based therapy because this would be easier for her in terms of our ability to navigate this care plan with her. So that's an example. The satisfaction data we can point to is that we had a goal. We want to educate patients like this about the relationship between their physical health and their psychological well-being. And in our data, our satisfaction data, the suggestion is that over 90% of them have a much greater appreciation of how these two areas impact these kinds of chronic conditions and what their role is in terms of optimizing their health care. But there are challenges, and I'll end with this thought. The first is that there are tremendous psychosocial issues. And the collaborative care model, as powerful as it is, must account for concrete services and delivery of those services. And we need our behavioral health colleagues, our field-based colleagues in the community to work with us on that. And the second is that the collaborative care model is only as effective as your ability to remain faithful to it, to be, to maintain fidelity. And quality measurement around fidelity is absolutely critical in terms of making it work. So we all have to be honest with ourselves about where it works and adjust treatment, and where it doesn't work and think about the additional resources we need to bring to bear. Thank you.
I just want to comment and maybe plant a seed for questions in the discussion to Richard's point before when he talked about incentives. So being in the New York area, I've been aware of Montefiore's really leadership and innovation in pursuing this way in advance of most healthcare, particularly academic healthcare systems. So a question that I'd like Henry to address subsequently, and again gets back to the issue of how do we incentivize systems to move towards this. Why did Montefiore sort of move forward in this way in advance of their peer institutions? So Dr. Frank deGruy has been a major figure in the family medicine field and has thought long and hard about these things even before collaborative care became kind of a trendy topic to talk about. Frank?
Thank you. Yeah, I'm glad I lived long enough to see this day. It's been a long time coming. I really appreciate the American Psychiatric Association and Milliman and the people who spoke so far this morning, who are developing progressively refined and evolved understandings of what it takes to give good care. I'm going to just make a couple of comments from the primary care side of the river, just to kind of give you a look into what that world looks like and how it's operating right now. About a decade ago, particularly in the world of family medicine, I mean, we tumbled to the fact that a different kind of care was necessary if we wanted to be any good. If primary care was going to work, if it was going to do good in the world, that it needed to be rendered in differently than it up to that point had been. And all kinds of stuff happened. The chapter heading is Health Homes, Patient-Centered Medical Homes, a form of care that appreciates the need to meet certain criteria. And there's a set of researchers and a body of literature that supports the fact that primary care has value under certain conditions, if it's sufficiently comprehensive, if people have access to it, if it's coordinated, and so on. There's not much controversy about that at this point. There's agreement that primary care is only useful, let's just say, for example, if it's sufficiently comprehensive. And it hasn't been, it isn't. And one of the largest shortfalls in comprehensiveness has been the relative neglect of behavioral problems, mental health care, health behavior change, substance abuse, in the conduct of ordinary primary care, particularly family medicine. So if we want to be, if we want to be in some ways responsible for helping to accomplish the triple aim, if we want primary care to be cost effective and effective, then we need to incorporate into the fabric of ordinary primary care mental health care and behavioral health. So we know that, that's going on. We've been dealing with the consequences of trying to make that reach. We have partnerships with psychologists, psychology, social workers, nurse clinicians, care managers, and even community health workers who have certain kinds of special training. And all of that's really good. All of that helps. There's this problem that has been incompletely addressed that is, in my view, from my side of the river, still the elephant in the room. And that is what I call the deep end. There's this certain subset. With adults, it's about 20% of our patients who have mental health, mental disorders or mental health care needs, or who have major health behavior change issues, complicated, comorbid behavioral and chronic disease problems, substance abuse problems, such that I, as a clinician in the primary care setting, either don't know what's going on, but I know this patient is tearing up my waiting room and scaring me because what I'm doing isn't working, and they don't like it, and neither do I. And it's costing a lot of money because they're showing up in unusual settings and not getting good care. Or the problem might be well enough understood, but it's, as some of our panelists made reference to earlier, for example, diabetics and depressed patients can pass a certain threshold of severity where I've tried 2 or 3 things that I know to do that I'm comfortable with respect to managing their depression, not getting anywhere. And I'm thinking the next step is going to require, let's say, using medications that are going to destroy their diabetes control, the deep end. I can keep going. There's a set of problems that represents about 20% of those patients who have behavioral problems of some sort in the primary care setting. where I need psychiatry. I need a psychiatrist. And this goes right to the point of the Lieberman report. They kind of talked about the problems that cost us the most, the ones that are the most difficult to manage, the ones where we have the most to gain by doing well. Those are the ones who are in the deep end. Those are the ones who, even today, aren't being managed well. And what it takes in order to manage those well is a psychiatrist partner who's a physician problem-solving, pattern-recognizing partner who helps me put together a coherent, internally consistent personal care plan for the whole person care of a patient. So that's one thing that we ache for psychiatry to do with us, as well as function as a team leader. There's a bunch of behavioral clinicians operating in primary care settings. That team needs some sort of coherence, needs to be rendered effective so that those elements of a behavioral team that are needed at the time are deployed appropriately. We need education. There are certain kinds of problems that if I just knew a little more, I could manage effectively instead of ineffectively. There's a need for consultants and referrals. There are times when at the end of the day, this is not primary care, this does not belong here, help. And having that kind of working partnership, close access so that we can move back and forth across the river under those circumstances is really important. And finally, participating as a system architect to figure out how to design the system so that the incentives are aligned right, so that we don't get defensive and territorial about who's responsible for what. Believe me, there's enough work for everybody here. So that we learn how to share information in such a way that it's respectful and appropriate, and that we learn how to flexibly move into the circle of the active team for patients, in and out of that participation and active contributions to a personal care plan as the severity of patients' problems rise and fall according to the effectiveness of our care. So I'm really glad to see us coming to this day. This feels really good to me. It feels like the most important missing piece of what we need in rendering comprehensive, integrated, coordinated, effective primary care is right at our threshold now. So thank you.
Well, as we said, Frank has been saying this for a long time before it became fashionable, but I think we can genuinely say that the APA in psychiatry hears you. So, Keris, Myrick, Keris, maybe you'll share with us sort of your thoughts on this approach, particularly from the perspective of consumers and family members.
Sure. So first of all, I'd like to thank the APA for their work on this and work on integration and inviting NAMI and myself to speak. So this is a very personal issue for me because when I first started to work, and by the way, I'm going to have to read a little bit because I will go off script. So keeping me kind of in the box. So when I first started this work in mental health about 6 years ago, I wasn't on the job long before I was receiving emails about colleagues and friends who had passed away. And these were all peers, people living with mental illness, and they were not much older than myself. The statistic about people with mental health diagnosis dying years earlier than the general population, as much as 25 years, was no longer a statistic, but they were people, they were peers who were advocates, providers, families, and friends to myself and others. And lucky for me, I was approaching my 50th birthday. Yeah. So I knew that, I didn't want to be a statistic or be the fate of what I called at the time the Manderscheid or Druss statistic from their research about mortality rates of people diagnosed with serious mental illness. Further, I didn't want any more of my life stolen or lost due to disability, distress from symptoms of my illness, side effects of medication, and or evading the doctor to assist with identifying preventable and treatable diseases that were stripping the years off of my life and the years of my friends. So I'm very fortunate as the president of NAMI, of the board of NAMI, and also a CEO of a large peer-run organization. I have the ability to learn about these issues related to our whole health care, which includes integration of mental health, physical health, and substance use disorders, and share this information, advocate for integrated services that are person-centered and driven, holistic, culturally based, and influenced, recovery-oriented, trauma-informed, and of course, effective. In 2011, NAMI did a survey of the field and working with an interdisciplinary team published several reports about primary care. One was called the Integration of Mental Health in Pediatric Primary Care, and another was the report on the family experience with primary care physicians and staff. And of note in these reports, the family feedback was focusing on creating welcoming environments, inclusive of having resources in the lobby and information in the lobby of mental health and wellness to sort of normalize the whole thing and not have it be sort of that secret thing you gotta whisper. Having access to a variety of resources and supports for family and children, and the needs for pediatricians and primary care providers to inquire early and often about the child's feelings and behaviors and how they are doing in school, with friends, and in their communities. Further, that follow-up must follow if needed and care taken in gathering the information in ways that children and families will be comfortable sharing the information and hopefully in reducing stigma. What I hear from my peers is that people with personal lived experience of mental illness is that they want to be treated as whole persons rather than being seen and treated from the neck up. So we say that we'd like the recognition and desire to be treated from the neck up, down, and all around. There are many of us that wish that all of our needs, inclusive of physical health needs, can be addressed in community mental health centers where records, information are readily available, where they feel the providers, inclusive of psychiatrists, nurses, peer providers, and wellness coaches, they all know them. While we have others who look forward to a team approach of primary care with mental health care done in a seamless fashion without judgment and focused on the person's identified goals for their physical health and whole health wellness. And they also are interested in learning self-management and wellness management techniques. We hear from others, from peers and families from various communities of color, where they consider their primary care physician as the place for their whole health care, as they are reticent to access mental health care in the community due to shame and stigma. Also, peers and families have fears about primary care's ability to see the individual as fully human, which may result in perceiving information through the filter or lens of a diagnosis or symptoms. Therefore, some peers and families are reluctant to share their mental health information with their providers. So we have a working definition of recovery from SAMHSA, which says, that was done in 2011, that says recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And there are 4 domains of that working definition, which include health, overcoming and managing one's disease or symptoms, and making health-informed health choices that support physical and emotional well-being. Home, having a stable place to live. If you don't have a safe place to live or a place to live at all, it's kind of hard to follow treatment. Purpose, having meaningful daily activities and independence and resources to pursue them. And community, which is social relationships and social networks. Under the health dimension, I think definitely within healthcare reform, ACA, and integration environment, the major dimension of health within the working definition of recovery is supported and can be operationalized through person-centered and driven care that involves shared decision-making, holistic approaches, and further with the projected newly insured that may stress our already overburdened resources, partnering with paraprofessionals, peer providers, certified peer specialists, wellness coaches, recovery coaches, system navigators, promotores, add them all in there, along with utilizing the strengths of our community's natural resources for integration and improvement in the health and mental health for everyone. And I think it's possible, actually I know it's possible because I did it. I did celebrate my 50th birthday. I do live in Los Angeles, so you can guess where I went. Where'd I go? Disneyland, thank you. So 15 years prior, I had been to Disneyland for my first visit as an adult, and I declared that I was the saddest person at the happiest place on earth. Several days later, I was committed to a psychiatric hospital, and I sat in my room, and I was unclear about what my future would be. I had gained a tremendous amount of weight from the medication, which inhibited me from exercising, being social, and had me very worried about developing diabetes and other metabolic syndrome disorders. By partnering with my psychiatrist and my primary care physician, a nutritionist, walking in my community, and biking to the beautiful Huntington Gardens and libraries every day, I did recovery. I lost much of the weight, still have a little ways to go, and have celebrated a few more birthdays past the 50. So it will take a team approach, as APA has demonstrated today by bringing everyone together, and the person receiving services must be an integral part of that team. So do you guys think we can do it? All right, I do too. Thank you.
Well, Keris, thank you for those comments, which not just addresses sort of your thoughts about integrated care, but goes well beyond to what comprehensive services are needed for mental health care. It reminds me of hearing Mike speak repeatedly about, it goes well beyond just what happens, when you're in the clinic or you're in the office or you're in any kind of mental health setting. David, so primary care extends across the life cycle, and a key part of it, in fact, maybe the best opportunity we have, is to identify and act sort of in childhood and adolescent years. Could you share your perspective with us?
It starts with pediatrics. I want to thank the APA for the invitation to be here and to sit here and give you the perspective from the child's chair. We not only share initials with the APA, but also a commitment to mental health and mental health issues for children, adolescents, infants, children, adolescents, and young adults. The Academy has been very active in interest in the field of mental health for probably at least the last 10 years as well. That it started with several facts, and the facts were already elucidated by the panel in several respects. One is that probably 20% of kids in the U.S. have some significant mental health or substance abuse issue, that only a quarter of those kids at most get diagnosed and treated. Dr. Hogan mentioned the entry into mental health issues beginning in childhood, majority beginning by adolescence, and the identification of those kids being so important. The other facts are that there's going to be an increasing demand for mental health services, and in pediatrics particularly with the paucity of child psychiatrists, that the availability of psychiatric help for kids requires that we take a lot of that burden in pediatrics and in primary care. The primary care setting really is an optimal place for all the reasons that have been mentioned in both identification, early intervention, counseling, guidance, and coordination, and chronic illness management, and enhanced access to outpatient mental health services. It makes economic sense, the whole purpose of the meeting today. So I think the Academy started with those 4 facts, and based on that, developed 3 principles. That families and children need access to mental health screening and assessment and a full array of mental health services in a medical home, that primary care clinicians in a medical home must be recognized as a portal of entry to mental health services and to the identification of behavioral and developmental problems in children and adolescents, that primary care clinicians and families must have continuous access to consultation within the broad mental health community, and that lastly, payment for assessment and treatment for mental health problems must be adequate and comparable with payment for other issues. So what the Academy did was 10 years ago, they made mental health one of the strategic priorities as part of our strategic plan. They developed a mental health task force that's been active for the last 10 years. The task force has developed a mental health toolkit, and the mental health toolkit was designed to address 2 major issues. One was practice change and what practices might need to be able to be adequate medical homes for mental health issues. And secondly, the toolkit was a compendium of information about pediatric implications of mental health issues with an educational component. Furthermore, as part of our continuous professional development, we've had an active mental health track in all of our continuing education meetings, to be able to give pediatricians the tools to deal with mental health issues on a primary care level. That is part of the work of the task force, that we've developed a very active website, and we have lots of access to successful programs that our members can look to and go online to see what some of the successful programs have been. A major direction that the task force has taken has been the idea of co-location, and we have a list of a dozen or so positive co-location programs. In September of this year, we had a webinar with our PPAC, which is our Private Payer Advisory Council, to look at both the implications of co-location, effective methods of getting co-location into primary care offices, and looking at some payment strategies, working with some of our pediatric councils, which work with some of the insurance companies, to see if we could start addressing some of the issues of payment and cost for these services. That on a state level, that many of the states have tried to put in place some consultation models. I think this has been based on the Massachusetts model. Maryland has just started a BHIP program, that's a behavioral health integration in primary care program, where psychiatric consultation from a child psychiatrist is available by telephone 24/7. I think within 24 hours of the demand. So you see a patient in your office with an acute problem, and that you can get support from a child psychiatrist in both the initial management and the disposition. Information about medication, information about treatment course, support in doing what you want to do in primary care, as well as availability of research. Well, they'll help to identify and get resources for you for treatment of that patient. The 4 components of that program is phone consultation, the primary one, continuing education, research and referral networking, and social work co-location. The program is a jointly sponsored program from the University of Maryland, Johns Hopkins, and the Salisbury State School of Social Work. And lastly, I want to mention Bright Futures, which is the pediatric tool for the delivery of primary child health care, of primary child health care. So when you come in the office for your visits, and the structure of that visit is outlined in Bright Futures. It gives us our periodicity schedule and gives us information and services that children require at each of the visits. And it looks very broadly at health issues, so that it looks at developmental issues at each of the visits, it looks at psychosocial and mental health issues at each of the visits, as well as the medical issues at each of those visits. And there are a number of screening tools and things to support the clinician in delivery of primary care mental health as part of comprehensive well-child health care. From my own perspective, I've had the opportunity twice in my practice years to have co-located services. We had a developmental psychologist with us for several years, going back a little while, and more recently we had a social worker as part of a project to identify the precursors of child abuse. So we did a 9-month-old questionnaire looking at issues of domestic violence, family domestic violence, family substance abuse, food insecurity, and depression. And based on that, had a social worker with us in the office who was able to identify those issues as they came up. Both of those experiences probably were the best practice opportunities I've had, feeling the most complete and accomplished at trying to do what we were trying to do in the office. One was grant funded, and obviously the grant funds are gone. But they're great models and great opportunities. So I'm thrilled to hear the implications for primary care, the implications for pediatrics, and the work that's been done by the American Psychiatric Association. I think that there's hopefully a future, and we're all going to have a chance to live and to see.
Thanks, David. We're running short on time, but I do want to try and squeeze in a couple of questions. And first, I don't know if it's me, but it sounded like Frank was portraying a situation where, general primary care and family practice was not sort of as well, had not responded, it was not as sort of well equipped to deal. And it sounds like pediatrics is really mobilized, but my sense is there's still a tremendous sort of unmet clinical need and lack of adequate integration. But I don't want to put words in your mouth, but Frank, is that do you think there's a disparity between adult and pediatric, or it's just that David was painting it in a rosier picture than it may actually be?
Well, I was painting a picture of the steps that we're taking. We're taking those steps because I think the clinician is not ready to handle. They don't have both the information, the ability, or the courage, if you will, to handle a lot of primary care mental health. So I think that pediatrics has always been a prevention-oriented specialty. We've always been very developmentally oriented. So some of the things that I've talked about, we've done for years, and I think all pediatricians are comfortable doing it. As we broaden the definitions and ask more and more mental health capability from primary care pediatricians, I don't think they have all the skills. And this was a response to that fact in trying to do an education program, the mental health toolkit, some of the programs that have been put in place, and to give them those tools.
Frank, do you want to comment?
I think the difference between how behavioral and mental problems in the pediatric population and the adult primary care population are managed have some important differences. They do. They have some important differences. I described about a 20% of behavioral problems in the deep end. That's for adults. If you go to family practices and look at what's the deep end for kids, it's probably more like 50, 60%. Those patients scare us more. I would say that there is more in common. I don't want to minimize the differences between the pediatric problems and pediatric issues in adult. They're important differences, and we need to respond sensitively to that. But the world of primary care, whether we're talking about pediatric patients, young adults, old adults, shares a lot in common in its need to produce comprehensive coordinated care. The details are different, but there's so much in common. I think the message that I would like to leave is that we're all moving in different areas. There's not an enormous discrepancy between how we look in the world of getting it right for kids and how we look in the world of getting it right for adults.
Henry, can I just ask you to respond to the question I posed earlier, which is why did Montefiore sort of really get out in front and innovate here? And also in this context, there was a question about what kind of adaptations or measures need to be taken to address cultural groups, particularly the Hispanic population where English might be a second language.
Absolutely. I think Montefiore's journey on this is very early in terms of looking at it from the standpoint of equity, to be perfectly frank. You know, when you think about the complexity of the patients that we've been serving in the Bronx for such a long period in time, clinicians were very aware early on that we had to have an approach to behavioral disorders the same way that we had to medical disorders. So the early attempts were, quite frankly, things like, you know, basic co-location or trying to fast-track referrals and to create better access systems, if you will, through our Department of Psychiatry and our community partners. And we developed different kinds of incentive mechanisms internally to foster that kind of access. So for example, if a patient is in our network where we take some form of financial risk for that patient in our health plan relationships, they have virtually no problems, should they choose, to access formal behavioral health care in usually 7 to 10 days or less, which is unheard of if you think about it in our network in the Bronx, where we have a voluntary network of physicians. But even that was not enough, Jeff, because as we all know, many of our consumers and patients prefer to receive some form of behavioral health care in the setting in which they're most loyal, in the setting in which they're most comfortable. So developing that option started off with co-location with, quite frankly, the outgrowth of the federally qualified health centers, who really took the early lead in this. So we have federally qualified health centers, and they started that model, if you will, but that wasn't enough. And part of the advent of the ACOs, if you will, is that now that we're joining the payment streams between the traditional sort of behavioral health carve-out, taking that away, putting that into the entire pot, we can make more rational choices. And now we can look at our network and say, wow, where is the population that has the highest cost and the greatest utilization with the behavioral health needs. And we're going to put resources right into that, both field-based as well as, I call it sort of care management-based, that's hovering over the entire process. But clearly we're in a time where payment alignment and payment reform is going to be the impetus for us to move quickly on this front.
Right. No, the economics are clearly driving it. It would have been good if we had done it on our own initiative, but this is going to make it happen. So just on this issue of location, Keris, so I'm going to pose it. It doesn't have to be an either or, but I'm going to pose it that way just to frame the issue. So would you rather receive your primary health care in the setting where you receive your mental health care, or vice versa?
Well, I'm a busy lady, so having it in one place would be great. But I think where the person prefers to have it is going to be a couple of different things, as I've heard. Is some people prefer to have all of their health needs in the mental health care setting. Others prefer to have it the primary health care. Some people don't want it either. And I think we have to be really careful of starting to duplicate things that are in the community that can help with health